So now we're going to look at a more complicated scenario where we have the agonist initially given. Agonist effects are short-lived, so we have those effects wear off after we see some changes, and then we introduce an antagonist. And an antagonist is going to cause changes, but the important consideration in these experiments here is that the antagonist effects are going to persist while we are going to be injecting the agonist for a second administration. So we have what's called the XYX format. X initially without any antagonist, effects wear off, I'm back to baseline. Then I give the antagonist by itself to see what it looks like, and then we give the agonist a second time, and I don't have that shown here what those changes are. We're going to talk about that in a second, but those changes could be given to you, likely to be given to you. So let's take a look then at the antagonist. Now, this is a building off of the previous example, so we're going to assume that we've already figured out that the agonist is norepinephrine. So we've identified agonist X as norepinephrine. So we've already determined that, and we still have the receptors that are responsible, the effects that are responsible for those changes to explain why this is likely to be norepinephrine. Let's take a look now at, after we've gone back to baseline, we introduce antagonist Y, and now we see some changes, and we're going to go through the same systematic approach that we did for the agonist. So the possibilities are, in this case, are 4 antagonists. Atropine, which is a muscarinic antagonist, it blocks M2 and M3 receptors. Phentolamine, which is an alpha antagonist, and we're just going to focus on its antagonism of alpha 1. Trimethophan, antagonist to the NN receptors. Those are the cholinergic receptors that are in between the pre and post ganglionic neurons for our consideration. And propranolol, non-selective beta antagonist, blockade of the beta 1 and beta 2 adrenergic receptors. So, like we did before, we can go and take a look at the diastolic blood pressure, what happens when we give this antagonist. And we can see right there, going along with number 1, the diastolic blood pressure fell. So now we take a break, we go and say, what can we eliminate? So if we go to atropine, the receptor that would be the only one to be considering here would be the M3 receptor, because the M3 receptor is found on vasculature. Remember, for the diastolic blood pressure, we want to look at the diastolic blood pressure and think about the systemic vascular resistance. Well, remember that the parasympathetic division does not innervate the blood vessels for the most part, and there's no acetylcholine activity for you to block. So even though atropine would be blocking those M3 receptors, those non-innervated ones, since there's no acetylcholine there for the receptor to antagonize, there actually wouldn't be an expected change in the diastolic blood pressure. So we would expect that the diastolic blood pressure would not change. And so we can actually eliminate then atropine from this consideration solely because the diastolic is falling, and we would not expect that from atropine. Now we go to phentolamine. That's an alpha 1, in this case alpha 1 antagonism is what we're going to be thinking about. Remember, alpha 1 receptors are on the vasculature, they're on the smooth muscle, they're coupled to GQ, they increase calcium, they cause vasoconstriction, increasing SVR, increasing diastolic blood pressure. And normally we have sympathetic tone, right, to the blood vessels, and there's some constriction of the blood vessels naturally to give us our resting SVR. So if we block the alpha 1, since there is some tone there at rest, there's sympathetic alpha 1 activity that you can block, you'd be blocking that constriction and the blood vessels would relax. You would lower the systemic vascular resistance, and you would expect to see a lowering of the diastolic blood pressure. So that would be a consideration here. That could explain this drop, would be alpha 1 blockade from phentolamine. So that's still a possibility. Trimethophan may not be so obvious, right? Trimethophan blocks the NN receptors, and in this diagram, this is just showing effects of the autonomic nervous system on the SA node, but please remember that the NN receptors, they're always on the postganglionic neurons of both the parasympathetic and sympathetic divisions, And if I block the NN receptors, I'm not only just blocking them here, but I'm also blocking them on the sympathetic postganglionic neurons that are going and releasing norepinephrine onto those alpha 1s. So because you're knocking out the entire autonomic nervous system with a drug like trimethophan, right? You're blocking all these NN receptors, so there's no autonomic tone. Because sympathetic tone to blood vessels is the exclusive division of the ANS that's present even at rest, right? Even though the sympathetic system activity at rest may not be a lot, it's still there, and you can remove it, causing a vasodilation effect. So trimethophan, by virtue of removing the sympathetic system, that would then cause vasodilation and also a lowering of the SVR. And by the way, the NN antagonists, when they were originally developed many decades ago, they were originally developed as antihypertensive drugs because of this effect. As you could imagine, inhibiting the autonomic nervous system everywhere is going to result in a lot of adverse effects, which makes these drugs not really all that appealing. And there's plenty of excellent antihypertensive drugs now that have really supplanted the NN antagonist. But in this experiment, the key is that you are expecting to see a drop in the diastolic, and that's what we do see here, and that could be explained by a drug like trimethophan. For propranolol, blocks beta 1 and beta 2, and the beta 2 receptors, while they are on blood vessels, and we discussed earlier that they do cause vasodilation, there's really not a lot of epinephrine tone that's present on blood vessels. And so even though you might expect blocking those beta 2s might cause vasoconstriction, generally we would not see that here. And the effects of the beta blockers for our purposes either are going to be not much of a change or possibly even a slight decrease because of the effects on heart rate that we had discussed earlier. The bottom line, though, is that we would not expect to see a substantial change in the diastolic blood pressure, and it would be negligible for our purposes. And so we can eliminate propranolol here for that reason. Now, as we're going to see, the next step, looking at the pulse pressure, that's going to that would have, if we took propranolol to the next step number 2, we would have eliminated it then anyway. But let's just get rid of propranolol. Okay, and that leaves us with phentolamine and trimethophan. So as we saw with the agonist analysis, looking at the diastolic blood pressure changes is very important because it can help you eliminate a lot of your possibilities. All right, and now we look at pulse pressure, and that should further narrow it, maybe. So if we look at the pulse pressure effects, we can put in here, you know, say, well, actually, we see that the systolic and diastolic fall by about the same amount, and this pulse pressure actually is about the same as it is there. So there's actually no change in pulse pressure. Let's see if we can figure that out. Well, phentolamine doesn't have any effects on the beta 1, right? Remember, beta 1 receptors are going to mediate the inotropic effects, so we wouldn't expect phenylephrine to do anything to the inotropic state, at least directly, and therefore we wouldn't expect to see much of a pulse pressure change. Now, you could argue that there's some effects of, we didn't talk about this in the previous videos, but there is effects of heart rate on inotropic state. There's also baroreceptor reflexes that could be occurring. So there's complicated things that could be happening that you could maybe see some changes, but for just a simple example like this, where it's not changing, we could say, well, phentolamine, that could fit phentolamine because there's no effect on the beta 1. Trimethophan is a little bit more complicated because trimethophan, because it knocks out the NN receptors are part of the sympathetic division. So you could say, well, indirectly, you're knocking out the sympathetic system and therefore less sympathetic tone to the beta 1 and inotropic state would fall. And that might be true. However, there are some of these other effects that we discussed on stroke volume that can start to cancel things out with that sort of effect indirectly on the beta 1. And also there's some interesting effects of heart rate that can be on inotropic state that could counteract this sort of effect that we might expect. We might expect it to fall, but it tends to be that it's about not it's about the same. It doesn't really change very much for a simple experiment that we're discussing here. So for our first pass through this, we could say trimethophan could be explained by a no change in pulse pressure. So we're really left still with these two drugs, and we don't have any clear-cut answer, right? We can't really separate trimethophan and phentolamine yet. So let's look at the heart rate. We haven't done that. We haven't done that yet. So if we look at the map is falling, right? And so we would maybe expect with a map falling that there would be a concomitant increase in heart rate through the baroreceptor reflex. But you got to be very careful. Phentolamine, because it's lowering the map, we certainly could expect to see a withdrawal of the parasympathetic system and a turning on of the sympathetic system, and that could explain the heart rate going up for a drug like phentolamine. The baroreceptor reflex is intact. But for trimethophan, which would be blocking these receptors here and here, by blocking these receptors, what you would be doing is you'd be removing all autonomic tone, and the heart rate would actually go up because you're taking away all autonomic input, and the heart rate would go to the intrinsic rate. So normally the heart rate is lower than its intrinsic rate because of all this acetylcholine at rest from the parasympathetic division. But if you take away both divisions, the heart rate will rise because of the dominance of the parasympathetic system at rest. So the heart rate could also be going up with a drug like trimethophan, not because of a baroreceptor reflex, but because you're making the heart rate, the SA node, go to its intrinsic rate, which would be increasing from a lower rate. So now we have a problem. We don't really know still, is this phentolamine or is it trimethophan? We are undecided. And that's generally the case for these two antagonists. When you're looking at their effects alone, you generally cannot tell them apart. Okay? And that's what we just went through here. So the only way to really figure out which antagonist we're talking about is to look at what happens when we give the agonist again. Because based on what happens there, that's going to tell us what's actually going on. So I don't have that drawn in here, but I'm going to draw it in now. So I'm going to give the agonist again. And I want you to pay very close attention to the first step again. The first step tells you a lot, as we've seen. And I'm going to make this look like this and like that. And this goes up a little bit. And this is going to go up. Okay? So, what is going on here? If you have to look very carefully. Do you notice that what was causing the diastolic blood pressure to go up in the first place, we already knew this is norepinephrine, was alpha-1. That was the receptor that was responsible for this change. Now, if the drug was blocking alpha-1s on blood vessels, and that is the receptor that's possibly what we're considering, we would expect an attenuated effect on the alpha-1 if it was indeed phentolamine. Because when you give norepinephrine the second time, if those receptors are blocked, then the norepinephrine is going to have a harder time activating them. So notice that the change is blunted here. Now, I could have made it also flat to show that it's completely blocked. You know, sometimes depends on the dose that's given, but what we see is that there's a change. The change is that the diastolic blood pressure is not going up the same way that it did the first time. That immediately tells us that it has to be phentolamine. All right? If it was trimethophan, trimethophan blocks the NN receptors. The alpha-1 receptors that are on blood vessels that norepinephrine was activating, those are untouched by a drug like trimethophan. So if you give norepinephrine in the presence of trimethophan, we would not expect to see a difference in the change in the diastolic blood pressure the second time. So it's actually only this effect right here. We know right away that phentolamine is the more likely antagonist. Why? Now, let's take a look at the pulse pressure. The pulse pressure goes up. Well, that's expected. The beta-1 receptors are not blocked by phentolamine. Okay. The mean arterial pressure goes up, but it doesn't go up as much, and that's expected because the diastolic blood pressure didn't go up as much. And look what happens to the heart rate. It actually goes up. And the reason why that's happening is because the MAP now is not going up as much, the beta-1, so if we go and we can say this is still, right, over here, a blunted increase in diastolic blood pressure. So that was the critical finding, right? This is still a beta-1 effect, right? And this now tells us that the direct beta-1 effect is greater than the indirect baroreceptor response. Okay? So that would be the way that you would use the agonist in the presence of the antagonist to try to figure out the identity of the antagonist. Now, that's not always necessary. When we look at an example of atropine or propranolol, those are actually pretty obvious what those are, and you may not have to look at what the agonist does in its presence. But it's good to go through the exercise anyway to try to figure out why are the changes happening when you give an agonist in the presence of an antagonist. And it's a really good review of the physiology, autonomic receptors, the cardiovascular system, as well as the baroreceptor reflex response. So we will look at other examples, but this was the first one of norepinephrine, phentolamine, norepinephrine. And we will go and continue to look at other combinations to review this material.